So, who am I? I'm actually a health scientist, which is like a climate scientist. Nobody listens to us, okay? I've been in academia since 1982. I started at Northwestern University, got my master's degree, then got my PhD later on when I was at Los Angeles at USC. And then I did a postdoc in brain science at UCLA. So, coming from Los Angeles and being an alma mater of USC and UCLA, I can say that I go both ways. Right now, neither one of them will hire me. And I left USC because we weren't addressing population health. So I'm an actual scientist who understands what population health means, what prediction means, what sensitivity means, and what cluster analysis means. And I'm a little concerned about how some of these terms are being used right now. I mean, they're great marketing terms, but I think we have to have an honest discussion about what the implications are to human health if we market and use terms in a way that actually defies the law of science, okay? So, I first want to say too, I am here because we're all on the same team, all right? And I hope that I'm gonna leave here with connections that'll help me get the word out about what technology needs to consider, okay? Because there are some serious breaches in confidentiality and the use of health information that you would be upset about if you knew that your health information is being bought and sold, okay? And so that's, I really want to have those discussions over the course of the 2 days. Okay. Since we're all business people, I like ink because they have good titles to articles that get you thinking. Why the right answer to the wrong question is still the wrong answer. You have to start with figuring out what problem you're solving instead of searching for the answer. So there's no question in my mind that in this room are the people who could solve the right question. But you would have to know what that question is. So I'm going to say that the right question is, how do we achieve the triple aim of healthcare reform? All right? So the Affordable Care Act has created tons of business opportunity. But if we don't think about what is the triple aim, and does anyone here know what the triple aim is? Let me show you. The triple aim of healthcare reform is better health of local communities, better healthcare by Medicare-compliant ACO providers. ACO means Accountable Care Organization. At reduced cost to Medicare HMOs in any global city. So whatever city in whatever country, that should be the outcome. So how do we improve efficient and effective healthcare? And we can't get to that outcome if we're competing with each other. So right now, I'm unemployed. I'm the #1 interventionist on post-stroke recovery. I'm a brain injury specialist. I haven't seen a veteran in 3 years. I haven't seen a person with stroke in 3 years. Think of all the people who need me and are not seeing me. So your job is to make sure that every single brain injury person in the whole world sees me or someone like me, because I have students all over the world, and they're waiting. They want to give health care, okay? So if we're not giving health care, then we're not solving the problem, all right? So I've already been having interesting discussions, and I just want to point out our logo. So we are starting a nonprofit think tank that's going to work on creating solutions. So that's why I was really happy to be here. But I want you to look at that logo that's in the middle there. And I actually want all of you to take your hand and put your hand on your heart, your chest. Everyone, even the guys. All right, there you go. I know it's very emotional, but it's true. Okay, that logo represents you as a person, all right? The green symbol is knowledge from the medical profession, physicians, PAs, nurses, all right? Licensed professionals who are specialists in your medical treatment. Orange represents your physical health. Physical therapists, occupational therapists, audiologists, chiropractors, acupuncturists, nutritionists, alternative healers, all are part of your physical health. Red is your oral health. And I don't know why the health industry doesn't see that your mouth is part of your body, but believe me, when you have no teeth, people think you're stupid. But if you can't afford to get an implant, you're not stupid, you just can't afford to get an implant. All right, so oral health is a part of your health. And the last one is the most important, I think, is your emotional and spiritual health. Because if you're not emotionally and spiritually healthy, you can't be a human, and you can't be healthy. You can take your hand down. Now, if you noticed, everyone at the table also had their hand on themselves. So each of them, in my eye as a health professional, every single one of you is a potential patient. Any of you could have a stroke. I don't want you to have a stroke. I want to prevent stroke. But if you have a stroke, I want you to see me, because I'll make sure that me or any of the students that I've trained would know what to do with you, okay? And not only would they take care of you, they would take care of your family. Because when your health is affected, your family health is affected. If your child is hit by a car, they're in the hospital, which means they get a lot of green attention, but your blue is out of control. And if you're a woman going through menopause, let's face it, that whole thing's a mess. And the worst part about being a woman right now in healthcare is that I'm a woman. And so it's hard to believe that a woman could be a scientist, but she is. And so when I go to a physician, what I hear is, it's all in your head. I'm like, well, actually, it's one thing I agree with. That's my brain. And my brain is different than the person who was trained in a medical specialty, right? So they can only provide me the information they know. So it's the knowledge, it's what you know, and it's what you don't know. And I think the opportunity here is this inflection point. How can technology help others learn what they don't know? Because everyone's an expert. I know you're all experts. So how do we take this point in time and make the inflection point be something where we actually provide something that's even better than what we have now? And if anyone thinks they're an expert today, I don't think I'm an expert, because it's healthcare reform. Innovation will be what comes of these discussions. It's not going to be what I think, because whatever I think is wrong. It doesn't even apply anymore, okay? So I thought I would start off by explaining what I call population health. And population health would be here. I live in Los Angeles. There's 3 million people in Los Angeles. There's 10 million in the county of Los Angeles. And the county of Los Angeles we're larger than 42 states in the union, just the county of Los Angeles. So we are a great little petri dish of reality, all right? So we just take Los Angeles City, 3 million people. Now, when you take the people, you split them up into children, adults who aren't on Medicare, and Medicare, because that's the payment system. The payment system pays for children, non-disabled adults, and adults who are on Medicare. All right. Now you can split those two groups into 2 different buckets. One are the healthy people, and then the other are the people who have special needs. So children with developmental disability, adults who've had a stroke prior to 65, or if you're 65, you're already disabled, you're 65. I'm 4 years from there. So when you get to later age, we know you're going to have more chronic health conditions, and you're going to be at greater risk for falls and things like that. So if we just take in Los Angeles today, what are the population of people who need Medicare Part B rehabilitation recovery services is 408,000 people. okay? Quite honestly, while I would love to have 408,000 disabled people, I can't take care of them myself, all right? And this is where technology could come in. Now I'd like to talk to you about cluster analysis. So in Los Angeles County, we have 10 million people. In Los Angeles, we have 3 million people. And then next week, we're moving to our new location, and we're going to look at a cluster within the population. So when I say cluster analysis, I'm looking at microeconomies. So this is the art district of downtown Los Angeles. It's a 2-mile radius. And within the 2-mile radius, there are 165,000 people, and 44% are female. So if I want to market to the females, I go market to the females. If I'm interested in public health, I want to take care of the whole population, okay? So who's in the population? Well, this is the breakdown of the population. You don't have to read all of it, but the point is that for women, their income is going down. So they're actually at less payment than what the men are getting because there really isn't a place for us to get a job. So there isn't any place that actually services women's health needs. So from a business perspective, if I were you, I'd jump on the bandwagon of women's health with me, okay? Because we could create business opportunities that actually meet the need of the public who are women who don't want traditional medicine. They want alternative to drugs, okay? They want more natural integrated health care. Okay, now, within that population are other clusters. There's a large homeless population that's growing in Los Angeles. Now, 100% of the people in the circle have coverage. Think about this. They all have health coverage. They're either well-to-do people who have private pay, they're eligible for Covered California, some subsidy from the state, or they're Medicaid. So of the homeless population, 100% of them have coverage, but 100% of them don't have access to health care, all right? So it seems that a business opportunity is creating access points for people who have coverage to get health care, because actually their health care dollar is not being spent, so someone's holding on to it. I think we should try to get it. So who are those people? The homeless are mothers and children who've been abandoned by their spouses or partners, the mentally ill, physically disabled, and seniors with dementia. You can tell who's a senior with dementia because they don't have a tent. They are on the sidewalk, wrapped in a blanket, wondering, where's my son or daughter? They don't even know they need a tent. They didn't even know they could get a tent, all right? So what are the consequences? High cost to the city of Los Angeles, high cost to our hospitals, poor health of the homeless, and health insurance, but no health care for children or adults who live below the poverty level. Now, in green, I didn't put the name of the big brand HMO, but it's a big brand HMO in the state of California who has 6 million members. And the blue part are the providers. And I can't get a contract with the big brand to be a provider, okay? So this is what healthcare actually looks like. I don't even want you to read it. I just want you to think of the degrees of freedom I have to control if a person who's a member of a health plan is going to get rehabilitation services from people who know what they're doing, who want to give integrated health care but can't, okay? So we need to look at technology from both sides. How does it look like from the payer side, who's paying a lot of money, the consumer side, who's paying a lot of money, and the public health system, who's not getting anything for all the money they're paying? So how can we do well and do good? So basically, I'm thinking it could be through technology like blockchain. So what could this mean to increasing access to affordable, timely, effective health care for underserved populations? Well, guess what? I have a license. I'm a driver. If somebody has a health insurance card, they're a passenger. So just to give you an example of a case that I was asked to consult on, Here's the Child Poverty Collaborative in Cincinnati in northern Kentucky. Half their children live in poverty. So here's a test question for all of you. Their goal is to get 10,000 children out of poverty by 2021. How will we do it? You're going to help me do it. We're going to give their mothers a job. All right? Because if the mothers get a job and are out of poverty, the children go with them. All right? So that's the co-op idea. So HEDI is the nonprofit who will be the trusted entity. I'm standing up here. I have no conflict of interest because I have no job. But I am working with people who want to come up with a solution. So if HEDI had technology partners, health service partners, and financial partners, then all we would be doing is connecting the people with the health license, the person with the MPI number, with the person who has a Medicaid number. And then you have a transaction, right? And now there's an incentive for the physicians and the nurses and the therapists to actually work together to coordinate care because you guys are helping us. And not only that, all the service providers who have great ideas, great products, it's like Etsy, you know? There's lots of great ideas out there, but lots of books and things like that. But we need something like Etsy so we can say, hey, look, try these things. You have equal access to it. It's about equal access. So why is this valuable? Because the solution is, how do we provide population health to the whole population around the whole globe? We have to do it through having a trusted entity, which is a nonprofit think tank that will monitor our behavior, because clearly we're behaving bad right now, and we'll get paid from the government, from Medicare in the United States. It could be from I'm going to Brazil at the end of May to talk to public health, because I think it's really the governments who need a solution, and it's the business community that can provide the solution, which is why I left USC, because I didn't think the university was ever going to be able to think in such an innovative way. Now, this is just to give you some idea of the money that's being wasted right now that could be translated into profits. So if there's 409,000 people who need a health home. So they need this integrated care, 409,000. Now, the issue right now is that the referrals from the physicians, they're not incentivized to make a referral to an alternative level of care. They're incentivized to write a prescription, which is what we don't want them to do. We want them to pick an alternative. And there's lots of physicians who want to pick an alternative, but they don't have one, all right? So we can incentivize them by saying, hey, you have two choices. You could write a prescription, or you could get an encounter fee for every time you make a referral to the health home, and every time the health home advises them on nutrition, exercise, whatever, you get a fee for that too. So now your patients are getting integrated care, and you're the conductor. But we have equal say, because it's a network, right? Now, if I got 10% of the people in Los Angeles at the rates that they're using in New York, I could make $9.6 million per month by creating an alternative integrated practice group compared to what we have now. That's a lot of people getting the right thing. And we're talking about a lot of money going to the right thing. And actually, everyone will be a winner. We're just reestablishing the supply chain by looking at what the person needs. So this is, basically my last slide, which really says, if we put the person and the family in the center and provided them the medical, physical, oral, and emotional integrated care that they need, they can choose options that will improve their health. But right now, if they have to pay for that, there aren't enough people with cash, free cash, that can do that. So we have to provide a global solution. So I want you to ask the right question and thinking about that for the rest of this meeting. And I'll keep challenging you on, are we asking the right question? Thank you.